Good morning, everybody. Thanks for joining, or I should say afternoon. It's noon now. Thanks for joining us at the table for our August Lunch and Learn discussion. I'm Beth Field, and I'm the Program Director for the Leadership Alliance for Neurodevelopmental Disabilities, or what we call LAND. We're the backbone organization of the Collective Impact Initiative called Meet the Need NC, which is funded by the North Carolina Council on Developmental Disabilities. We're also a program of the 501c3 Mental Health Transformation Alliance. Meet the Need is driving change for the developmental disability community across North Carolina. We're working towards meeting the service and support needs of the whole IDD community, those with IDD and their families. We're very excited also to announce that LAND has been informed that the North Carolina Council on Developmental Disabilities has continued our funding for another year, starting October 1st. Thank you very much to them. And this also means that our Lunch and Learn webinars can continue, as well as you're going to be hearing more about our Lived Experience Network, who will be woven very intentionally throughout all of our programming now. Today, I'm excited to have a group of longtime supporters of LAND. Here are two clinicians. They join us today with Duke, with a different lens than when we've had other webinars. Dr. Gary Maslow, he's a practicing medical doctor and psychiatrist, and Michelle Franklin is also a practicing nurse practitioner, and they're both, of course, researchers. Both care deeply, as I do, about the concept and practice of health equity. They'll overview how they define health equity. We have representatives from the Hispanic, Black, and Indigenous communities on the call today, and we decided to have a part 2 discussion with these communities because we thought that health equity deserved its own webinar, so that we could get our hands around what that means and who's included in that group of populations that are not being served as well. We will again save that for the future as we continue to forge more authentic relationships with these groups. Inclusive accommodations are available today. You'll see that in the chat. We have ASL interpretation. We have Spanish translation. We also have, I'm not sure if we've got cart captioning today or other text captioning, but that will be, do we have cart captioning, Devika?
Unfortunately, cart was not available today, but we are running captioning that is available. So I apologize for any inconvenience, but we will be able to send a transcript of this recording after the event.
That's great. That's great. I'm going to now introduce you, just to read you a little bit about both of these, your speakers today. Dr. Gary Maslow is the Associate Professor of Pediatrics and Psychiatry in Behavioral Health Sciences, as well as a co-chief of the Division of Child and Family Mental Health and Community Psychiatry at Duke University School of Medicine. He earned his undergraduate medical degrees from Dartmouth College and then completed the triple board residency at Brown University and a Master of Public Health at UNC Chapel Hill. He's a general pediatrician and a child and adolescent psychiatrist. Through his clinical practice, he provides primary care for children with autism and other neurodevelopmental disabilities and medical conditions. His research focuses on improving the outcomes of young adults with chronic illness. In addition to leading a diverse research and clinical portfolio, Dr. Maslow is leader and founder of the North Carolina Psychiatry Access Line, or NCPAL, which many of you know about here today. Michelle Franklin is an assistant professor of psychiatry and behavioral health sciences at Duke University School of Medicine as well, and core faculty at the Duke-Margolis Center for Health Policy. She earned her bachelor and master's degree at UNC Chapel Hill, and she's achieved dual certification as a family nurse practitioner and family psychiatric mental health nurse practitioner. She completed her PhD at the Duke School of Nursing, followed by a postdoc at Duke-Margolis Center for Health Policy. She also is has been very active with us within the LAND, Leadership Alliance for Neurodevelopmental Disabilities, and with our Meet the Need grant. Both Michelle and Gary have been funded or continue to be funded from from NIH, the National Institutes of Health, the North Carolina Development of Health and Human Services, the Health Resources and Services Administration, Medicaid, the Substance Abuse and Mental Health Services Administration, Patient-Centered Outcomes Research Institute, and Blue Cross Blue Shield NC Foundation. So I'm just going to remind everyone who's been here before and those new ones who with us here today, you can put your Q&A, you can put your questions in the Q&A box at the bottom of your screen. We'll only be answering questions within those Q&A boxes. You can put them in while our speakers are speaking, and after they are done, we will be having a short Q&A session with those. Michelle and Gary, welcome, and thank you so much for being here today.
Beth, thank you so much. And it is just a pleasure to be here with you. Thank you for this invitation. So it's one thing to tell people, but it's another thing, and it's even better to show. So we're going to do our best to show what's happening and why it's critical that we address health disparities that the IDD community is experiencing. So you can go to the next slide. Let's see. I don't actually see the slideshow. Do you?
No, just 1 second. I was showing my email by accident.
Sure. Real life, it happens, right? There you go. So you can go to the next slide. Perfect. And if you want to move it into presenter, and I think we're good to go, right?
Yes, presenter tends to.
I do it on the bottom, but wherever you want to do it. Okay.
How's that?
Perfect. Love it. Thank you, Jessica. All right. So we are going to do our best to show what is happening and why it's critical that we address the health disparities that the IDD community is experiencing. So I'll begin by telling you how I first saw unmet needs, health disparities, and inequities up close, what that really looked like to me. In 2012, I began traveling across North Carolina, providing medical and psychiatric services to people with IDD. And as I began seeing patients in the counties you see circled here, I began to realize, wow, where the person lived, it really matters. If they live in or near a city, they may have access to great services and support, but it can be incredibly difficult to get the help needed if they live in a small town. Across the state, I reviewed medical records for when people with IDD were seen in an emergency department or in outpatient clinics. And I quickly recognized that many patients were not receiving the quality of care that a person without IDD receives. I saw that it was important to have preventative care, but that preventative problems and care for that was like being missed, being skipped. I saw overprescribing of medications. I could see that providers didn't seem to have a good understanding of IDD or weren't confident in providing that care. I heard parents describe how difficult that transition from adolescence to adulthood had been for their child, and that the lack of resources, particularly once they left school, was so difficult. How isolated their child became because of this was also a big concern. Sometimes I met families when their child was in crisis and they were having to make hard decisions, like for their child to move into a group home. I'll never forget one mom in particular who sat across from me in tears, and she said, "I feel like I have failed my son. We tried so hard, we had a plan, but it was not enough." I knew that she had not failed her son, and I reassured her of that I had heard many stories like theirs. They were not positioned for success. I heard families' frustrations about waiting for services, including the innovations waiver, and wishing they had learned about it sooner. I saw examples of families who were white, had more education, money, connections, that they seemed to be able to get plugged into services easier. It seemed much harder for people of color, people with less time, money, or connections. Amazing mentors helped me understand that by getting a PhD and beginning to do research and health policy, I would be able to address these problems on a broader level instead of seeing them, case by case, day by day. So as I began my PhD at Duke, I was told that I had to meet Dr. Maslow because he was passionate about this work too. And from my very first meeting, it was just really clear to me that he understood why this all mattered and that he would be a great partner in this work. So we have been working together for over 7 years, and we are excited to share some of the work that we have been doing with you today. So you can go to the next slide. And you're going to see our agenda when we go to the next slide. That's perfect. So today, this is what we're going to discuss. First, I'll define and describe these terms. What are health disparities? What does the term intersectionality mean? What is health equity? And why is that our goal? We will share a bit about health disparities happening across the US, what we've learned in North Carolina through several of our research studies. And then lastly, we will share some projects that we're doing to address these problems and impact positively the health of the IDD community in North Carolina and ways that you could potentially get involved. So next slide. We're going to talk about health disparities so that we know that there are differences. We know that people with IDD are at greater risk for certain conditions based on their cause of IDD. For example, if you have IDD, you're more likely to have seizures. If you have Down syndrome, you're more likely to have heart problems. So we know a person with IDD has differences in their health that a person without IDD may not. But when we talk about health disparities, we are focusing on what is preventable and necessary to help people reach their best health. The CDC defines health disparity as the preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. Next slide. So Healthy People 2030 spells it out even more. They say health disparity is a particular type of health difference that is closely linked with social, economic, or environmental disadvantage. Without that disadvantage, and with the right supports, people would be much healthier. So we know that health disparities adversely affect groups of people who have been systematically experiencing greater obstacles to their health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory or physical disability, sexual orientation, gender or identity, geographic location, or other characteristics that are historically linked to discrimination or exclusion. We just want to make sure that we are talking about the same terms and that we are using that in the same way. So if we go to the next slide, you'll see there are 5 main domains that affect health. These are where the obstacles to health happen. The healthcare setting and healthcare access and quality listed at the top is just one of the domains. Medical care is estimated to only account for about 15% of modifiable contributors to healthy outcomes for a population. So we know that a person's social connections and community, having enough money, their access to quality education, and having a neighborhood that is accessible is crucial for health. These are social determinants of health, and they are the conditions and environments in which people are born, live, learn, work, play, age, etc. And they affect health, functioning, quality of life, all the things we really care about. So let's go to the next slide. And here you're going to see that there are 2 main ways that we examine health disparities. We are concerned about health disparities when comparing the general population to the population of people that has IDD. We know that if you have IDD, you are more likely to receive poorer quality of care, have less access to care, have worse health outcomes, are less likely to be employed, and many lack the social opportunities that you may need to be healthy. We're also really concerned that when we compare groups within the IDD community. So for example, people from historically marginalized communities like people of color or indigenous people and people living in rural areas are more likely to experience obstacles to living a healthy life. Then we think about the age groups. There are particular periods of development that are particularly vulnerable. So when we think about the transition to adulthood, we know that it's a difficult time for adolescents and young adults, and it's particularly difficult if you are from a racial and ethnic minority community. Again, most at risk for poorer health, worse outcomes during that transition to adulthood that is so important. So let's go to the next slide, and we will briefly look at this example around life expectancy. So that's the average of how long people live. In 2020, the life expectancy for the general population was 77 years of age. But for example, people with Down syndrome have a shorter life on average, as they typically live closer to 60 years of age. The good news is that is much longer than it was in 1983, when the average lifespan was around 25 years. And again, those domains that we just reviewed, because of improvements in all those areas, quality of life and length of life has improved, but we still have so far to go. Mortality rates among adults with IDD are much higher than for the general population, with over a third of death being preventable, potentially preventable with healthcare intervention. So that highlights that things are being missed, people are suffering unnecessarily. An example would be pneumonia that is missed. That could be a common cause of death. So let's go to the next slide. So people in racial and ethnic minority groups and communities are most at risk for poorer health and less access to disability benefits, community services, routine care, when compared to people who are white and have IDD. One final example I want to give you is with children. If a child is Black or Latino with autism, they're more likely to get diagnosed later, have lower quality of health care and less access to care compared to children with autism who are white. So we can go to the next slide, and I want you to see, I'm trying to show you here what intersectionality looks like. This is a fancy term that really means that and reminds us that everyone has their own unique experiences of discrimination and oppression. And the ways our society identifies us in these different ways, they overlap. And as you can see here, can cause people to have even greater disadvantage. So one example I'll give you is a Black woman who is queer and is disabled is even more likely to experience the disadvantage and health disparities that I've been describing. Let's go to the next slide. So I'm sure you're wondering, what is causing this? What is causing these disparities in care and services? There are three really big ones. One, lack of educational preparation and the experience of healthcare providers to do this work. Number two, stigmatization, discrimination, and segregation towards people with IDD. And third, institutional and cultural racism towards individuals who are also from racial and ethnic minority groups. You will be seeing ways that we are trying to work on that through the current projects that we're going to be sharing. Let's go to the next slide. So health equity. Remember that term if it's new to you, health equity. It's super important. It's our goal. Achieving health equity requires addressing health disparities and removing these obstacles to health. Removing these obstacles that I've described: poverty, discrimination, lack of access to good jobs and fair pay, quality education and housing, safe environments, and quality health care, so that everyone has a fair and just opportunity to attain their highest level of health. And as you see with the picture in the corner, we need equity, not equality. Some people need more supports to be able to have a fair and just opportunity to be healthy. In this picture, it means to see over the fence. To see over the fence is an example that here would mean having a full and healthy life that they deserve. So we're going to go to the next slide. And this is where we're going to be sharing more about the research that we conducted and the problems that we have identified in North Carolina. And I'm going to turn it over to Gary.
Hello, everyone. Thanks for having us. And thank you to Beth and the whole Disability Council and everyone joining today, as well, and especially to Beth for really leading this work, which, again, it's been amazing to see how it's grown. So yeah, thank you for having me here to be a part of this this presentation and this initiative. So I'm going to speak more about some specific North Carolina research. And I wanted to start from, again, situating it from my perspective as a primary care pediatrician who has been in North Carolina for 15 years. And so I started as a primary care pediatrician, and I'm also trained as a child psychiatrist, and I was doing about 5 or 6 half days a week in primary care. And I will be totally honest, again, as a specialist and someone who also is doing primary care, I had no idea about the innovations waiver. I had no idea about home and community-based service waivers in general, and I really missed the boat. And again, as someone with extra training, and I feel like I've felt very guilty that for 5 years I really did not know at all about the systems of care for my patients with autism, intellectual disability, or other conditions. And I think Karen Lukin, who many of you know is an amazing disability advocate, I don't exactly know how I got connected with Karen, but she connected me with the council's work previously on the home health initiative, and how important it is to really have medical homes that not just focus on the physical health, but also on the helping young people and adults and children with IDD thrive. And from that, I learned about the innovations waiver. And one of the first things, if I could have the next slide, that helped me situate things was looking at my own clinic. And so we have a clinic that has over 30,000 children and young adults with who are in the Durham Triangle area at Duke Children's Primary Care, Pediatric Primary Care. And we basically ran a query to see how many of them had an intellectual developmental disability using kind of data from the UHR, and we identified almost 500 patients. And I had this amazing social worker who was working with us named Amanda Zaspy, and Amanda went through and reviewed almost 500 charts, and to basically pull out information related to these individuals. And I'm not going to go through all the information, but out of these almost 500, there were 345 who had an autism diagnosis. There were 48 with Down syndrome, 91 with an intellectual disability that were documented in the medical chart. And again, I'm going to come back to they were documented in the medical chart. This is where disparity may begin, in that sometimes someone who may have Down syndrome and an intellectual disability, only one of those diagnoses is actually visible in the chart. And so we have a real problem with kind of invisibility. There were also a lot of comorbid mental health conditions that were documented. Can you go to the next slide? We then looked at and did a lot of other things, but one of the key things we looked at was how, who is their MCO? And, we're in Durham, so the majority of our patients have Alliance. There were some with Cardinal prior to, this is 5 or 6 years ago. About less than half were getting any behavioral health services. And again, only 17% were getting any behavioral therapy, which again is, when you have individuals with IDD, having that low a number getting behavioral health supports is quite low, and lower than what we would really want. But this is what struck me the most, was that out of this population of 500, 49 or 10% had received a waiver slot, and 11% were on the registry. But almost 70% had never been screened or even evaluated. And that difference between the number, 500, and that are potentially eligible, and only 100 who are either on the wait list or getting the service, was quite disturbing. And I felt very acutely my role as a pediatrician where I had been seeing patients for 5 years who likely would qualify for the innovations waiver, and I had missed those 5 years of getting them on the wait list. And that, I think since then, the last decade, since I kind of learned about the innovations waiver, it has become a real focus of what I am studying, but also advocating around, that we need to identify individuals with IDD, children, young adults, adults, and connect them to needed services, with innovations being kind of a marker. And our success with getting folks identified and on the registry, I think, is related to whether they get services in general, not just innovation waiver services. So again, this I find is a very striking finding. I'm going to talk about some of what we've done to follow up on that finding and a little bit more quickly. Next slide, please. So the something else we looked at, and just we started looking at education data, thinking about, okay, here's a county, how many kids in that county have been classified as having intellectual disability, which is ID, or having autism, and how does that match up with the county level? Oh, you can go back, Sarah. Can you go back one slide? Thank you. That's forward. You can go back 2 slides. But one more, yeah, okay. Thank you. We could look at, okay, again, this is in probably 5 or 6 years ago, how many children in the county, let's say in 2017, were classified as having an intellectual disability or autism, and how many were on the waiting list? That just gives you a rough count. So in Orange County, there were 93 children in school who were identified as having intellectual disability and coded that way. There were 319 with autism, so that's about 400. Well, the total number of children on the waiting list was 88. And so there are 400 children in school identified, but less than 88 on the waiting list. And again, that seems like consistently, that's just a huge difference. And maybe not all of those patients, all those children would qualify, but it is a much larger gap than we would expect. And similarly, if you look at Vance County, about 275 children with intellectual disability or autism, and only 15 were on the waiting list. And this both points out the challenges related to a more rural county connecting children to the wait list, but also it points out the other disparity that we notice, a difference, that depending on where you live, whether you're coded as having intellectual disability or autism or another school classification, is very different. And so in Orange County, many more children were coded as having autism, and in Vance County, many more children were coded as having intellectual disability. Why this is, what this is, I can't fully explain, but there's not a biological reason why there'd be such a difference, in the classification. The next slide. So we've dug into this in more detail. And again, this is looking again at by race. When you look at, there are approximately 1.5 million children in North Carolina in school, again in 2017. And of those who were white, 10,000 were identified as having autism, and those who had intellectual disability were about 5,000. So twice as many white children with autism as a classification versus intellectual disability. When you move over and look at non-Hispanic Black children, it was flipped. There are about twice as many children who are classified as having intellectual disability as opposed to autism. Again, no biological reason for this. Something is happening in our system that is leading to this difference in classification. Does that difference in classification then lead to healthcare outcomes differences? That's one of those things that when you go from a difference to something being more of a disparity. Next slide. This just gives you a map, and counties that are redder are counties that there was more autism versus intellectual disability, and counties that are bluer, it's vice versa. There's more intellectual disability coded in schools and more, as opposed to autism. And what you could see is that in the counties where there were more white students, there was lower diagnosis or coding of intellectual disability, and the opposite held true for Black students. That was not true for autism, but autism was related to income. And so in schools that had, in counties that have higher income, more students were quoted as having autism. And you go to the next slide. This is probably too complicated to try to talk through here, but essentially as you go up in education, the gap gets larger. And that's what these top graphs are basically showing. And it's more pronounced for mild intellectual disability. And you can go to the next slide. I'm going to talk about this next study in 1 second, but just to kind of put to summarize what we saw and what are, looking at the educational data, there are a lot of things that come up related to this. It's not that schools are doing the wrong thing necessarily, but there's something happening where there's misclassification, and again, we don't know which direction that goes in. And how does that misclassification in schools then translate into access to things like the innovation waiver? How does that misclassification in the medical record similarly lead to, or not being even identified in the medical record, lead to patients' children not getting identified by the systems and therefore not getting the services they need? I'm going to do this very quickly just because of our time. But essentially what we did was we looked at Medicaid data and we said, okay, how many individuals have an intellectual disability, autism, or another type of developmental disability in the Medicaid population over a given year? And there were about 53,000. Out of those 53,000, approximately 12,000 had a waiver slot. So there are the 12,000 had a waiver slot, and there are 40,000 who didn't. Again, not all those individuals with intellectual disability or autism would qualify for the waiver, but many would if we had more waiver slots. One key finding was that there were 75% of the individuals who had the waiver were adults over 21. And for me, as a pediatrician, that's a disparity. If you're a child, you're less likely to get this service, even though it is one that could make a huge difference in your life. So there are racial disparities, there are disparities related to income, there's disparities related to geography, and this is an example of a disparity where by age, you're less likely to get something because you're younger. And that, again, is something to keep in mind. When we look by race, if you look at the non-Hispanic white line, there are 27,000 non-Hispanic white patients identified, and 6,700 had the innovations waiver. So that's roughly, 25%. If you go to the Hispanic white category, and this is, again, these are categories that are in Medicaid data, you have 3,000 identified, but only 232 who had the waiver received, which is, less than 10%. So that difference between 25% if you're white versus 10% if you are Hispanic is a major difference, and I would argue is a disparity. Can you go to the next slide? One thing that we found in this study is that having the waiver was protective of going into the emergency room. And so that if you were someone who received the waiver, your risk of going to the emergency room was actually markedly less, 27% versus 37%. So 10% less ER visits just by being classified as someone who's had the waiver. Next slide. These are, can you go back? Sorry. This is the last slide about that I think I wanted to focus on, and then we're going to kind of skip through a little bit. But when you look at the risk, meaning what's the risk of getting, the risk is the risk of actually having the waiver. So it's a positive if you have a higher number. Again, if you look at by age, 0 to 17 versus over 21, it means that children as opposed to adults have a 61% lower risk of getting this service, or 61% lower opportunity to get this service. If you compare Hispanic white to non-Hispanic white, that 0.63 number, that means that Hispanics patients have a 37% lower likelihood of getting the innovation waiver. And if you look at non-Hispanic Black versus non-Hispanic white, it's 0.85, which again is a 15% lower risk. So these are quantifiable numbers to say the innovations waiver is distributed across our state in a way that is different by race. That it, to me, rises the level of the health disparity when you look at things like ER utilization. If you have this service, that is one thing that you can point to and say that is lower, and your health is worse because you don't have access to that service. So both by race as well as by age, there are clear disparities. There's a slight rural versus urban, but it's not actually very pronounced, at least in this data. And that's what probably because the way the slots are distributed is that there is, they're distributed by county in a way that really is meant to minimize the rural versus urban. Next slide. The next slide's a map, which again, I think just shows you that there's variation. We're going to skip over that. And I'm going to keep going. And I'm going to pass this over to Michelle, and Michelle can kind of talk through and talk about some other more qualitative studies that she's done and we've done related to the transition to adulthood. And then we'll have a little bit about things we're working on, but we want to get to the question and answer. So
Thank you, Gary, so much. Michelle, you've got about 5 minutes so we can get to Q&A, but wow, is that compelling data. Gary, that's alarming.
It is. It is. All right. We get it, Beth. We want to leave on a positive note, though. So we do want to save a couple minutes to do some of our projects. So I want to just highlight this here for you. Go hit forward a couple of times. You should see some quotes here that are going to come up, I think, separate there, and hold right there. Go back. Yeah, perfect. All right. So this is just a study. I would encourage you to read it if you're particularly interested in this transition to adulthood period, and you want to hear again more examples. And these are from interviews with parents. We did the study to say what is going well in the medical educational community and vocational systems as people transition to adulthood, and what is not going well. And this is what we heard. 3 big things: inefficient, siloed systems. They're not working well together. Lots of opportunity for improvement, lots of problems. Children left out here floundering in adulthood. So this person, this quote here is describing waiting for that innovations waiver slot that Gary spoke of. Hope despite uncertainty. And one of the big things they said that gave them a lot of hope was another parent that came alongside of them and helped coach them in this difficult time. So we knew that we need to make more investments in having parent partners, is what we call them, in the clinical setting. So we've been doing that. We'll share briefly a little bit more about that and how you can get included if you want to be. So go to the next slide. We are going to just very quickly talk about current projects. So NCPAL is going to go to 2 slides. Yep, perfect. So NCPAL, the North Carolina Psychiatry Access Line, free consultation and education program for healthcare providers in collaboration with the HHS and UNC. You see our great funders here that's making this work possible. It has grown from a phone line to just incredible programs doing really important work around the state. And if you go to the next slide, you will see that we do have an IDD specific work stream. And these are some of the examples of services that we are helping provide to primary care practices in North Carolina. And I want to draw your eye to that second box on the left-hand side, and that is about family partners. Again, hiring parents that have had this experience and giving them training and helping them work in clinical settings to really help parents and children. So go to the next slide. This is a project. I know we have some of our amazing advisory council members and steering committee folks on the call today. This is a project that we've been doing to make sure that we're doing research with people that have IDD, not on people, doing research that is really important to them and meaningful. And these are some pictures from a community conversation that we had with them in Durham. We will be doing one in Asheville in October, and we'll be sharing some information through the newsletter about that. You can go to the next slide. And this is just where we're showing, these are the 5 big things that are going to come out of this work. And we'll be finishing up in the next 6 months. And this is certainly going to help us do better research that really matters in North Carolina. And this will be shared nationally through PCORI. We can go to the next slide. And this is you, Gary.
One of the large innovations across the state is tailored plan. And as part of that, there are advanced medical homes, or the Advanced Medical Home Plus program. And so I think I'm excited personally about the opportunity to enhance primary care through tailored plan care management and this innovation that DHHS has put in place. We have 5 primary care clinics that serve over 1,000 patients many of whom have IDD, with the idea of improving their pediatric primary care and their family practice primary care, including for adults, and also connecting them to with services from, from including in the community, like the innovations waiver. And so we've already engaged some of them in some of our patients in primary care, and it's in care management. I think it's been a really positive change. But models of care like AMH Plus and Tailored Plan are, not fully here yet, but are a way to create health homes for individuals with IDD that can break down some of the silos that we were talking about earlier. The next slide. And again, we've been working with the Patient-Centered Outcomes Research Institute to create a roadmap for research in intellectual and developmental disabilities and accelerating that. And ultimately, the goal of that is to do this with a health equity lens and to reduce some of the known disparities that we touched on here a little bit. But hopefully, research is a tool, but it really comes down to the community and policymakers to implement some of the things that research can identify. And so it's both, we need a roadmap not only on how to study and improve our knowledge about how to help individuals with IDD and their families and their communities, but we really need the roadmap to improve all the services and systems of care. And I think Leanne and the council are working on that as well. Next slide. So I think that's the end of our presentation, and I think we're gonna now have some time to have a Q&A session with Anne and Beth and Sonia.
Thank you so much, Gary and Michelle. We're going to keep you here for a little bit longer. I'm asking the Q&A moderators to go to 1 o'clock, if you will, and then we'll have 5 minutes to just close out. So we're going to go a little bit longer today. I wanted everyone to hear this wonderful information, and I know there's a lot of questions in the Q&A box. We've got Ann Rodriguez, who's the executive director with I2I, and we also have Sonia Friesen, who's a psychologist, and she's with Juvenile Justice here in North Carolina. I'm gonna throw the ball to the two of you, and you can ask Gary and Michelle some questions. And when we get to about noon, I'm gonna stop you, and any questions that we haven't answered, we're going to go back to Gary and Michelle and see if we can get answers for you. And that'll be in our newsletter along with recording and the presentation. So go ahead, Ann and Sonia.
Thank you. Thank you, Beth. Thank you, Gary and Michelle. I think you have shown that having data helps us paint the picture of who's in need. And as you were saying, Gary, about having strong advocacy and the relationship that having that data is to public policy making is critical. And that's part of the reason that your presentation today is so timely. The first question is around workforce. We know that just increasing slots will not solve the issue that we have in meeting everyone's needs in North Carolina. So the question is around, are you all working on or familiar with any solutions to the shortage in psychiatry services across North Carolina, especially in group homes and ICF homes? So the shortage of workforce. And then speaking to the competency of workforce, are there services for adults who have nonverbal and hard to communicate level of skills? So those are the first questions that we received.
I don't know, Anne, Beth, Sonia, if you want to respond to these questions as well. I mean, I can tell you my perspective, but I'm certainly not an expert on this. I think we need to have the funding in place to support the workforce, and then we need to train the workforce and have the workforce paid adequately and the workforce able to get further support. And so we need a lot of workforce investment, as well as having more individuals have access to that workforce. Other states do this better. If you look at, New York State does not have a wait list. They have 95 or 100,000 individuals who receive services. And their state is only, they have 20 million people, we have 10 million. So they have, twice as large a population, but they have, 8 times the number of individuals who get support through the services like the Innovations Waiver. So I think there are examples of other states that have done this investment, but it is a pretty large investment and a commitment that would need to be made to really prioritize the care of individuals with IDD, including those who are nonverbal and have other communication needs. So yes, I think that's my perspective, but I don't know. I don't have to have all the prescriptions of what would address that.
Well, the good thing about our place, Gary, is we create a forum for you guys to say what you're thinking, and so that's just it. It's not necessarily representative of the whole community or land or meet the need or the DD Council. This is your perspective, so we appreciate that. And I want to move to New York, I think.
I know, or bring it here. That sounds like a good model that we could be following. And it's such an important issue that has to be addressed in so many different ways. And getting later into the questions, it's not just about psychiatry services, it's about services across the board, of course, direct support professionals, but even getting into primary care practices, pediatricians' offices. I think the data that you showed today showed how critical that is, into the community health centers, because that's where the people may first interface with the healthcare and behavioral health care and the intellectual developmental disability service systems. So I think Sonia's ready to pick up the next question.
Yes. So for either of you, thank you again, Dr. Maslow and Dr. Franklin. Are health disparities between institutional care and home and community-based services tracked?
It's a great question. So I guess read the question one more time, basically saying institutional care versus.
Are health disparities between institutional care and home and community-based services tracked versus those?
Yeah. So actually having a waiver. So I have not seen great data on that. I mean, certainly we know that, I gave the example about people with Down syndrome living much longer, and that one of the biggest drivers is people that are living in the community with control of where they live in smaller settings, in, communities that know them well, families that know them well, natural supports that are tailored very specifically to them. And so I feel like that is a big data need that I see from my perspective, to really know what are the services that make that difference between those two, what is high value. So we do have very limited money and resources. Legislators are making hard decisions with, again, some limitations there. So if we could do studies to really look at what are the pieces, what is doing right, what is helping in the institutional setting that can really be translated more effectively into the community, and how can we use those dollars well? High value care, that's really what we are thinking about. And so we have ideas on studies that we would like to do to get a greater sense of where those investments would be. But I cannot point you to a study right now that I think would answer that question, which is like, what is the difference? And kind of where is the magic wand between the two? I'll let Gary say, is there anything more you want to add to that?
I think if individuals are being institutionalized at a higher rate based on some demographic feature, that's a major health disparity. And so if the innovations waiver is in place and one of the things it achieves is keeping people in the community, you would imagine that those who don't have access to it are more likely to be in residential institutional settings. And so I don't think I don't know that data, but it follows pretty closely from the purpose of innovation, and what we know about it is to help people be in the community. And so if you do not have access to the service that keeps you in the community, you're more likely to be institutionalized. And so I think that, to Michelle's point, like, that data probably is somewhere in the system. That would be really important, again, to demonstrate what is a really big problem in our current system, that the distribution of resources is distributed in a way that isn't equitable. And so that the downstream consequences are likely worse health, higher mortality, not being able to live in the community. And those are not the current situation promotes that inequity. And that's one rationale for really trying to fundamentally change that. And I think trying to meet the need the way Beth is articulated.
Thank you.
So we have several points around this concept of things being preventable and early intervention, how important it is to get to parents. But I'm going to hone in on one question. Do doctors who see children with IDD through the Duke Advanced Medical Home Plus program talk to parents about paid and non-paid supports for their children? With the length of waiting lists, non-paid supports wherever possible will be important.
Yes, we are trying, and I think that's sort of where being a part of this initiative and learning, again, I feel like I've learned in every time, having done this for a decade, I have so much more to learn and learning from parents and advocates like many of you on this. So we definitely work with them, and the idea is that you actually have the medical team, the nurse practitioner, the physicians in the practice, but they're partnered with care managers who are nurses and social workers, and we're going to have family partners as part of our AMH Plus team who can help navigate paid, non-paid supports. Someone was asking about, how to other things related to housing, and that's the whole point of these AMH Plus programs, is to connect people to their full spectrum of needs.
Thank you.
Okay, there's one from a teacher, and talking about similar with linking to pediatricians, but also talking about the schools. And is there any kind of way that the social workers in the schools are more informed and others, so they can link young people that have IDD needs, particularly African American families, into services, and then in the school, but also outside of the school, into the IDD community, getting on the waiver list, etc. So the role of the schools and educating the schools about this area.
I mean, it seems like schools are such an important place for children, especially, and their families. And so, yes, I think, what is the strategy for schools are having IEP meetings, CBSAs are having meetings, like how do we harness all that energy and connection that exists in the school to get folks connected? And why is it so hard to pass information from the school to the medical system or the development disability system? If a child has an IDD diagnosis and classification in the school, why can't we just pick that up and hand it off? Why does it have to go through this whole bureaucratic paperwork process? Why can't one determination be enough? And I think that it's both on the schools to do education, but it actually is on us to maybe change the system so that once you are known to have these conditions, you are eligible for the service. I have patients on SSI who don't have access to innovations waiver because their testing was too long ago, even though they have they're getting a check for their disability. That just to me is there's just a huge systematic failure right now where you are classified in one system that's not acknowledged in another. And so yeah, schools, how do we work with schools? How do we all partner? How does the medical system do better by schools so that we can get them the information they need to get kids what they need? And obviously this applies into adulthood. And I know Michelle's thought a lot about transition. So when you are doing that IEP transition planning, what are your supports going to be when you become an adult and are no longer in school? And how does that fit in with things like innovations?
Yeah, and I would just add NC-PAL, that program that we talked about that Gary, really started back in the day. There is a school team, there is early childhood, doing work with CDSAs, really to try and answer some of these questions and again, break down some of these silos. So getting at what is really happening there and how we can do things better. Great questions.
Let me get back to the question I was going to go to. Somebody was asking something more, it's practical, but it's about having the resources as an advocate. So being able to take this information, and they were asking, is there a map or list of primary care clinics for AMH pluses or any kind of information like that they can use to help parents? Because that is most definitely one of our ways that we can successfully approach this is, and part of the whole premise behind Meet the Need is the more that we as advocates are educated, the more we can support people in our communities.
So the AMH Plus program, I think there are probably 3 or 4 in the state right now because it's just so new with tailored plans. I think Duke has one, I think ECU, and then I think MedStar's out in the Wilmington area. So those are 3 that I know of, but they're not a lot of programs yet. And I think when the tailored plans go live, one thing that we all can do is work with your alliance via the tailored plan in your region to help advocate for creation of more advanced medical home pluses. I think that to me, that's a place that the system could really transform in a really positive direction to bring the service array that's so separate closer to primary care, and then help with the physical, mental health and developmental needs have, a true health home that, Karen, I think, envisioned years ago with that initiative. So AMH Plus to me is like one tool that's brand new that could really be a part of linking the school to the primary care, to the LME MCO, to the developmental disability system. Like that I think is a really exciting but complicated thing. We're already seeing it starting to work. And so there are many other solutions that are probably more financial, but one that we already have in the toolbox is this kind of AMH Plus. That again, I think we'd be happy to speak our experience. I think having a statewide list of providers who have experience caring for individuals with IDD and primary care would be amazing. I don't know that we have anything like that. I mean, again, going back to the council's work previously with the Health Home Initiative, I think there are resources that were created there about helping practices be, IDD friendly, and again, part of NC PAL's work is to do that as well. So I don't know that it answers the question, but it is.
No,
there are
thank
things to do.
you both. And what I'm going to do right now is I'm going to cap things off, and Gary, I don't think you've been on our Lunch and Learn before, but Michelle has. I usually ask a question, and if you could answer in 30 seconds to a minute as we close things off. The big question is, can you give us something can you leave us with something? Can you leave us with a comment that kind of just summarize where we can go to act?
You want to go first? You want me to?
You can go, Michelle. I'll think a little bit.
I mean, I could answer it a million different ways. So the first thing that comes to my mind is just that if you are here, you are an expert. You have seen things, you have experienced things, you have a unique skill set. So speak up. And if you don't know who to speak to next, you want ideas, you can talk to us. You can reach out to us through email. We might have ideas. Just keep talking. And again, these Lunch and Learn experiences and just meet the need, I think, is really helping people have skills to know how to talk and making connections on who to talk to. So I would just really encourage you, share your stories, because that makes a difference. And we would love to share. If you were like, I want to share some data, I want give me a little card, or give me something that I can we can do that too. Sometimes having a little speaking piece can be helpful, depends on who you're talking with. But just don't be silent. Use your expertise, lean into that. And when I have really seen change happen, it is the people that have the lived experience. And when we do our best research, it's because people have told us what really matters. That interview, paper that I referred you to, that is a paper that I think really brings the concerns that transition to adulthood alive for people. And it is hard for people to read the words and the experiences of parents and families without doing something. When we know better, we do better. And we have to make sure that people hear what is happening. Because again, they might be completely unaware. I just try to give people the most generous explanation. They might be unaware. Make sure that you share with them, so that is no longer an explanation. So I think that is the main thing, that sometimes it's not what you need to learn. It might be sharing what you already know and what you are really passionate about. I'm glad to talk with you more about bringing those stories to life, if that's helpful.
I guess my thought, because as Michelle was talking and going through this, whenever I talk about this data, it makes me sad and it makes me mad. And I feel very very frustrated just by the current situation, and having had, someone who gets an emergency slot 5 years after we say they need an emergency slot, and they've now are in a group home or out in an out-of-home placement because of something that happened, because we were not able to get them access to services that would have kept them in the community. And so I don't know how to, I think this is a very helpful forum to be in, Beth, and thank you for leading this, because I think it takes some of that frustration and that despair, I would say, and helps channel it towards maybe we can do something different. Again, being in the state for 15 years and not seeing things change, it is hard, I would say, to maintain optimism and hope. And that being able to be in this environment where you have so many people who are working together, and the progress you've made just in bringing stakeholders together is reason for hope in what I think many of us find very dispiriting. So thank you. Thank you.
Thank you. Well, thank you. Thank you for coming to elevate this discussion to the place that we would have liked it to be a long time ago, but we finally have been able to get you to come talk to us. And we want this dialogue to continue. So we're gonna have you back, and we're gonna go to the next level of talking about health disparities. But thank you so much to both of you for joining us. Thank you for our Q&A moderators, our translator, our interpreter, and thanks to partners. They've sponsored our inclusive accommodations. Thanks also to our Meet the Need advisory group, our land advisory group, and of course to our funder, the North Carolina Council on Developmental Disabilities. Thanks for joining us at the table today. And hopefully you'll come to us next month, where we're going to be talking about the IDD workforce crisis. And we've got Dr. Pat Porter joining us for that. We know that will also be a lively discussion. Thanks for joining us at the table today. Be well.